my name's Tori and I wish I knew more about blood products.
Hi, my name's Letitia. I wish I knew more about taking care of myself when starting shift work.
Hi, my name is Lydia. I wish I would know more about how to work as in a team and solve conflict.
Hello, welcome to 5 Things, the nursing podcast from the Royal Brisbane and Women's Hospital. My name is Liz Crowe.
I'm Jesse Spur, and this is a podcast by, for and with the amazing nurses and health professionals in our corner of the world. We hope to connect with a global community as we move from surviving to thriving. Welcome to 5 Things.
Hello, my name is Liz Crowe.
And I'm Jesse Spur.
Welcome to another episode of 5 Things Nursing. And today we welcome Dr Karen Davies, who is going to talk to us about medication safety. And Karen is currently the Nurse Research Fellow at HIDI, which is the Hurston Infectious Disease Institute. And the reason she's speaking to us about medication safety is that she's normally the Safe Medication Practice Clinical Nurse Consultant here at the Royal Brisbane and Women's Hospital. And this was the topic of her PhD. Welcome, Karen.
Thank you for having me.
I'm always really excited to have someone that's thought so much about a topic coming on as a guest to discuss it. I realised in prep for this that we crossed paths probably about 10 years ago now. So that time went really, really quickly from when I was working here as a nurse educator. So it's great to have come full circle and be sitting at the table with you. In the spirit of that, obviously lots happened in that 10 years, but winding back a little bit further, what's your backstory in nursing?
So I was hospital trained here at the Royal, and so in those days we got the opportunity to experience lots of different areas around the hospital, theatres and wards and babies. The children's was part of our training as well, so lots of different experience, which was fantastic. I went on to work in the wards for a bit, and then I went to the emergency department for a year, which I loved. But doing the full-time shift work got a little bit hectic, and I ended up going to the hemodialysis unit, got Sundays off and didn't do night duty, so it was fabulous. But it also had the opportunity where it was there was a lot of technicality involved with looking after the patients and the machines, and they had a lot of complex medications and things. So it was really interesting work in the hemodialysis unit. So I was there, and I was the nurse unit manager there for 12 years. So I worked in renal for 20 years. And then this opportunity came up to look at accreditation, safety roles. And I was fortunate to be able to set up the safety and quality roles across the hospital as a project, and the medication safety role. And at the end of that, I went into continued in the medication safety role, safe medication practice we called it, and I've been doing that for 19, nearly 20 years. And so that's where my love of medication safety came in. To talk a bit more about that.
Wonderful. It's such an interesting area, and it doesn't matter who you are in the multidisciplinary team. This has got real relevance, because medication is such a big part of hospitals and such a big part of risk. So let's just dive straight into it. Your number one is communicating about medication is really important, verbally and written.
Yes. So obviously, if we're going to be giving medications, they need to be documented in the first place. We have to start there. For prescribing, we need to make sure that it's clear, it's correct, it's precise, it's legible, all of those things. And we're fortunate that we've got some national standards around that, or what are acceptable abbreviations these days, what might have been acceptable in the past. There's potential that we've learnt lessons over the years that there's things that may lead to errors, what we call error-prone abbreviations, and we try and avoid those sorts of things and standardise those things so that everybody knows what something means, instead of people trying to guess what that interpretation might be. And so we've come a long way over the years, that we wouldn't accept unclear prescriptions that potentially could lead us to those things, and we have much better and less risk in doing so.
There's a lovely quote that the worst thing about communication is the illusion that it's happened. And this is a really good example of that. So there's an order given, and then that's the illusion that that transaction's complete from one perspective of it. There's the reception of that order and interpretation of that order. There's so many faulty, leaky bits down the pipeline between the decision to give a medication to a patient and the diagnostic thinking that's gone into it, and the patient safely receiving that medication that is not going to cause a problem for them. You've sort of talked about that starting point with the prescription is obviously an essential component. There are a number of cases due to the type of work and the members of a multidisciplinary team working in parallel rather than together a lot of the time that can end up with situations where there isn't someone present to order the medication. So we'll look at things like a verbal order and stuff. What are some of the practice issues with that and some of the workarounds and safety controls that can be put in place with that?
Yes, clearly having verbal orders and phone orders, they can potentially lead to errors or misinterpretation. So we have a standard where we have two nurses listen to the order and read back to the prescriber over the phone what the first nurse has written down and heard to make it clear that they've actually it's been documented and heard correctly. So there are strategies to deal with that, but we do recommend, especially in high-risk medicines, that they're avoided as much as possible. Even in the a medical emergency situation, there's always someone documenting what's, even if it is a verbal, there's someone documenting what that is. But there is a great risk, as you say. Apart from that, what's perceived as being ordered, we know that there's a great number of medications that are omitted, and deaths related to medications, 30% of those are actually that the patient didn't get what they were expected to get.
This has been an area of interest for me, I suppose, that spun out of simulation and kind of looking at systems and reproductions of how systems work. And one of the things I found fascinating was this phenomenon of cognitive priming, when we're double-checking something and we're not actually double-checking it. We're being primed by the way that the person's asked us to check something. Yeah. And that's one with phone orders that I really wanted to make sure that the listeners were really clear on what you'd said, which is actually the loop being the prescriber articulate the order to one nurse and then the other nurse articulate that order back to the prescriber to do the check rather than independently listening to it. So having a process that avoids that going, hey, can you look at my 60 milligrams of Clexane that I've now primed you to see 60 milligrams of Clexane? And that's a real phenomenon, especially in a busy environment. And a funny thing about the literature on that is the more we trust our colleagues, the more likely we are to be primed to see what they've just told us.
Absolutely. And that's something that we do when we're giving education, is to try not to prime the person and to do and not say that and say, can you check my medication? So they don't know what that medication is and they actually have to look at it and read it because, as you say, it primes them to expect to see that and they may not read it properly. So it is a very important point.
We've kind of moved throughout most of the world to giving medications. It's being typed into a computer system or some sort of program. Is there anything that we need to be aware about in terms of that and communication?
Yes. So when we're going from computer to computer and patient to patient, we may end up actually having the wrong patient screen open, which is a great risk that the wrong patient will get something because we're looking at the wrong chart. And that can happen in the paper environment as well. A chart might be put back at the wrong end of the bed, and unless someone's checking the patient, that certainly can still be an error and getting the wrong patient. And we know that 65% of the time, patient ID is not checked correctly, and that's internationally. So it's quite horrifying, really, the great risk. We call wrong patient errors never events. We should never get the wrong patient. And we look at 3 identifiers: patient name, date of birth, and hospital record number.
All right, so your number 2 is the importance of involving the patient as a core member of the medication safety team. Tell us about that.
I'm really passionate about this. It is so important that the patient is involved and considered as part of the member of the team, because they're the ones with the knowledge about their medications. They're the ones that are going to be going home, managing their own medications. And we know that particularly for over 65-year-old patients, 30% of hospital admissions are related to their medications and problems with that. And a lot of that would be misunderstanding. So it's really important that they're part of the team. If we don't use open questions when we're talking to them, we use closed questions, we don't ask them what their name is, they may not have their hearing aid in post-surgery and they may not hear us properly, or they may have a language barrier and they may just nod when you say, "Are you Mary Jones?" And they may nod their head, not knowing what you've said or just agreeing, and then we can get the wrong patient. So it's really important. It's also when they come in, they may only remember one of their things that they're allergic to. But as time goes on, they might say, "Oh, well, I forgot to say that I'm actually allergic to this as well." So when we're giving patients their medications and we just say, "Here's your antibiotic," for example, they've got no idea what that is for them to be able to intervene and say, "Well, hang on a minute, that's something I'm allergic to." Whereas if we say, "Here's your flucloxacillin," they may say, "Oh, hang on a minute, is that like penicillin because I'm allergic to penicillin?" And they've got that opportunity to be their own advocate and to speak up and be informed.
Another example of that I've seen is patients have come in, they've had their regular medications as best obtained from digging up a health record, often from a prior hospital admission or whatever source they can get during emergency or the admission process. And if you go to them and say, "Oh, I've got your metoprolol," they're going, "Oh, actually my GP stopped that about 3 months ago," but there's been a gap in that record there. So really wanted to pick up on that point of actually saying what the medication name is, because I've seen those so many times where patients actually said, "Oh, actually, which one? Oh, yeah, no, they changed that," or, "Oh, yeah, I had a dose change of that recently," or, "No, the GP stopped that last week," and it hasn't integrated into the history.
Absolutely. It's exactly right. And sometimes, when we've got different brands of medications, if we talk in generic terms, then, and we have that conversation with the patient, I don't know all the brands. I've been doing this role but, out in the community, there'll be completely different brands to maybe what we've got in the hospital. We may have a brand that they go home on in the hospital, but they've got a different one back at home or that's provided by the community pharmacist. So if they understand what those medications are when we're talking to them, if we say, "I've got your metoprolol, do you know what that's for?" and we can have that conversation, then they'll know and they'll have better opportunities to be able to be compliant or understand why they need to be taking them rather than, "Oh, I don't think I need that today. It's not that important." And if they have that understanding, then we can educate. And as nurses, pharmacists do that really well. But as nurses, we're the ones that are seeing them every day, giving them the medications, and we've got that great opportunity to be able to provide that information and inform the patients so that when they go home, hopefully they're less likely to come back because they don't have that understanding of their medicines as well.
And we don't want to set up bad habits in hospital, do we, where we make the patient completely passive, like, "Here's your meds, take them." They don't understand what they're taking them, what time, what they can't have them with or without food. We want to be providing that education and empowering them to have agency over their own lives right from being inpatients, don't we?
Absolutely. So, it's, there's situations where, a patient may receive a subcutaneous injection, receiving insulin, not knowing what it is, and actually not diabetic, has someone else's chart. So if we engage in those, those patients would know, "Hey, I'm not diabetic. Why am I getting insulin?" But they normally would get heparin or Clexane for VTE prophylaxis during hospital. They wouldn't know what the difference is unless we're talking to them about it and being clear.
So your number 3 is to be aware of the risks and safety processes for medications. So what are they?
It's important that we're aware of what are the risks that we're exposed to when we're managing medicines, so we can try and avoid those particular things. And we get a lot of that information from past incidents and reported incidents. We have lessons learned from that. We've actually learned a lot from aviation as well over the years around safety, things like standardisation. Standardisation is key to ensuring that we minimise the opportunities for error. If everyone's doing the same thing then we're not having to learn different ways of doing it when we go to a different ward or a different hospital or a different state. And we're really fortunate here in Queensland that we have developed a lot of standardised medication safety charts. So the National Medication Chart actually stemmed from the Queensland Health one back in 2004, and it became a national chart in 2008. And every public and private hospital across Australia used that same form, and it was based on errors and lots of audits to identify what was best practice and what prevented errors. So we've also got things like the IV heparin forms, so the high-risk medicines, insulin charts, subcutaneous charts, IV fluid charts and electrolytes, and standardisation around how those should be prescribed and things like that, and how they should be administered and used. And that all makes for a safer practice environment when we're using best evidence.
Anyone who's interested in doing a deeper dive around medication safety and incident reporting, have a look at Amy Edmondson's work in psychological safety. She essentially conducted her PhD work around responses to incident and the ways teams talked about errors and looked particularly at medication incidents. So being open about mistakes, but ideally what we're looking at is learning from near misses rather than the coroner's report from a death due to a problematic heparin administration. And unfortunately, a lot of the big changes have been made historically around because of big adverse events. But yeah, really encouraging high rates of errors that didn't make it to the patient. They're the ones that are just gold for our teams to learn by, rather than going, oh, we've had a spike in medication incidents. No, we've had a spike in people going, whoa, that was close.
Yes, so really important. So we do, when we look at those incidents, we have medication safety committees as well, which is another strategy where you talk about what are the current trends and things. We do have to remember they're reported incidents, so that's really the tip of the iceberg that we're looking at there. And as you say, we want to learn from the lessons before they get to actually harm. We do know, unfortunately, though, that 3.5% will result in actually significant harm to the patient. And so fortunately, that's a small percentage, but it's still obviously significant. And we want to obviously try and avoid those.
I guess we've talked a lot about the risks. What are some of the safe practices that we can do with regards to medication processes?
So besides standardisation, keep things simple. Keep things simple and clear is one of my really key things. Things like making sure that the medication stays in its original packaging. So you can actually read the labels properly. You can read the expiry dates, because if you pull out a foil and the expiry date's on one end and that end's been used, you can't check those sorts of things. And that a foil strip can look very similar to each other, but if you have it in the original packaging, hopefully that will avoid things being mixed up. Things like ampules are a great one for that, because they can all look very similar. You can only have so many different colours of things and different variations, which they try and do, but brands or company brands will all be the same colour, no matter what medication it is. They'll all look the same. So it's we can't rely on look. We need to make sure that we're checking properly, and using the original packaging certainly helps with that.
Also, a big thing that you mentioned was the nurse's importance in this. And I think a lot of nurses feel like safety is something that's done to them. This is a comment that I've had a lot, is that rather than, there's been this loss of sort of, or maybe it hasn't just been built up, that nurses are the agents of safety in their workplace and can have great ideas, not just about responding to a negative event, but actually having really good ideas. So like the storage example that we started talking about is, if we've got two similar medications, storing them in different areas. So an example we had in ICU is we'd have potassium ampules and high potassium phosphate ampules, and by alphabetical order they'd be stored very close to one another. But we took the high potassium phosphate, which were I think 25 millimoles of potassium in them, and stored them in a cupboard that was near the Schedule 8 drugs. It's very separate from the others, so it really reduced the likelihood of there being an error for the most commonly used ampule of potassium with something that was significantly higher concentration.
Absolutely, and that's one of the key strategies. If it's not there, you can't make that mistake, and so that's a forcing function. What we talk about is trying to put in processes where there's forcing functions where it's not possible to happen. So we actually removed a lot of, except for ICU where they still need to have potassium ampules. A number of years ago, 2014, we removed potassium ampules by replacing them with pre-mixed bags. So we didn't need to have the ampules on the ward. It could be mixed up with water or saline ampules. We have pre-mixed bags now, and so the nurse, they don't need to be made up. So that means that it eliminated it altogether. But for key areas like yours, this strategy was lock them up somewhere else so that there can't be an error mixing them up.
Yeah, and some of that's just that seeing the empowerment that we have in our role to go, whenever we go to the medication cupboard and go, this is stupid. Yeah, it probably is. Let's do something about it, rather than every nurse that goes there for the same thing over 2 weeks going, this is stupid, this is unsafe, and then brackets afterwards, but someone else will do something about it, but the CNC will do something about it, but I'll shoot an email to the NUM. No, let's just address this and actually put forward a solution. And I think that's that kind of revitalising of the bedside nurse, of actually seeing that agency and safety, going, why is there 2 different concentration prescriptions for something that we use one? So we had in ICU an example of this where we had a potential prescription for 500 mics of fentanyl in 50 mils and 1,000 mics of fentanyl in 50 mils. The amount of times you go into the cupboard to get the 500 mic going, I wish it was a double strength order. We're having to change it all the time. So you're increasing all of these extra steps, in each of which has a potential for error. So we're mixing up medications. We're actually introducing an extra step, checking. So we ended up abolishing the 500 mics in 50 mils, which actually improved nursing workflow and has that compounding effect of you've got more time to put into attention on other things like checking all of your other high-risk medications you've got to give. So I think there's so many great unknown nursing-led changes that can still happen in your clinical area that I just using this as a bit of a podium to get on and go, just get out there and be an agent for safety.
Yeah, that's right. It's everyone's responsibility, and sharing those lessons learned as well. Recently, we reviewed all of the IV safety software in our pumps across the hospital. That included intensive care and cardiology and the general pumps and even the neonatal intensive care. And to streamline some of those things and to standardise them as much as possible across the hospital, so that when a patient was transferred from one area to another, we're not using different concentrations and then having to change lines and syringes and throw those drugs out and start again. IV safety software is one of the other safe strategies, is that in those pumps the drug library is there and you choose the drug and you can see that the medication is on the screen, so you know what drug is being given through which line. But it also has it's called dose reduction error software, where won't allow you to put in an unsafe dose. So if you went to put in 4,000 milligrams for something and 400 milligrams was the safe normal dose, it wouldn't let you do it. So it's mandatory that people use that IV safety software to prevent the opportunity for wrong dose errors. So that's certainly a strategy. And we also try and standardise that across the state. And we started with that. Sometimes you need to add additional things, but for the most part we try and standardise those, and that will help with patient transfers between facilities also.
So your number 4 is the important role of the multidisciplinary team in medication safety. Can you talk to us about who is in that team and what's everybody's role?
Yes. So in managing medicines, there's a lot of people involved. First of all, clearly the patient's central to that, and the patient's family and carers are part of that as well. Prescribers need to prescribe the medicine. Pharmacists, they often get the medication history and confirm the medication history from the patient, the GP, the community pharmacy to actually see, as you were talking about before, Jess, that what is making sure that we've actually got what they're currently taking, not what they may have taken, on the last admission even if it's only a few weeks ago, the GP may have stopped something or whatever. So there's also the GP and the community that are part of the team, and of course the nurses. Each one of those is obviously important and valuable. If the patients get home and they're actually not taking something because they may not be able to afford it or they don't understand, that can be really important as well in identifying that they actually, what are they actually taking? So that's some of the things that the pharmacists will do. Also, we have when it's dispensed and making sure that it is dispensed, that it's actually received. Sometimes it's sent to the ward and the nurses don't know it's actually arrived, and so medications can be missed. And when transferring between areas, some patient individual medications may not be transferred with them and left behind as well. About all of them coming together to get a complete history of what actually the patient is on, what they should be on, what they are taking, and what they should be continuing to take either during their admission or when they go home. Because something that they may start may not necessarily mean that they need to stay on it even when they're discharged.
I really like that because it touches on something that is being talked more and more about as a feature of high-performing teams, and this cross-monitoring of each other's performance, or essentially cross-monitoring for safety. One team member or constituent of the multidisciplinary team that we often don't formalise when we're talking about that is the operational staff. I've been really fortunate to work in places where the difference between, say, a pharmacy assistant, one of the wardies who's brought the medications and actually told someone rather than just putting them in the bucket where they usually go or putting them in the spot where they really usually go. And it's that prompting and cross-monitoring of performance that's just can make such a difference. That can make the difference between a patient getting that medication like now or in 2 hours' time sometimes. But by the time someone's habits or loops or rounds have gone back to, oh yeah, those meds that I've got to chase them up, oh, they're in the tub, but they've been there for 2 hours. So that was just, something I think we often forget about or just don't formalise those people into the team around or around safety in general.
Yeah, exactly. And that comes back to the whole core component, isn't it, around communication and it's, the best done verbally, making sure we actually do talk to each other instead of, like you say, just putting it into the box and the container. And that goes down to also ward rounds and things like that. Nurses being available and being on the ward round to see what's actually happening with the patient's medications, what is how they're responding to them. We've got such a wealth of knowledge about how it's affecting the patient, their response to that, whether their appearance are working, whether their pain relief is working. There's some of the things that the medical staff may not know when they're not actually with the patient every day like the nurses are. And we know also from studies as well here at the Royal is that changes of medications on those rounds, around 20% actually don't end up getting prescribed onto the chart or changed after the round and may not happen. If the nurses are involved in those conversations, then they can be a conduit and a prompt to ensure that those things can happen as well. So it's really so much about teamwork and working together and making sure that we do all work together and remind and prompt.
Okay, so your number 5 is really about drawing this all together, kind of restating what we've already said, and that is medication is everyone's business and we all have individual accountability for that.
So this is where my PhD came in. So one of my statements that each of us is accountable for our own practice and the patient outcomes that ensue from that. With our national standards, it says that we need to ensure we've got competent clinicians, but they don't actually tell us how to do that. And with nurses, there's not a standard way that we assess nurses' practice and ensure that they're doing all the points that they require for safe practice, everything we've talked about really already, and when we're giving medications. So I developed a tool in conjunction with the pharmacy and medical staff to assess nurses' practice. The nurses to self-assess against what are the best practice standards giving medications. So in Queensland Health, we have the 6 rights of medication practice, and that is that we've got the right patient, the right drug, the right dose, the right route, and the right time, and also the right to refuse if it's not clear, correct prescription. Then we've got the procedural steps. So we need to make sure that we're administering it correctly. We're using the IV safety software, that we're diluting it in the right strength, that we're administering it at the right rate, and that we're washing our hands using our 5 moments of hand hygiene, that we're using an aseptic technique when we're giving our IV medications, that we're documenting it, that we're signing that we've given it so that our colleagues know that it's been administered, that we're not documenting before we've actually administered it and it looks like they've received it, but in fact they don't actually get or take that medication. So that then leads to omissions. A key component of it as well is engaging with the patient, like I've said previously, about making sure we use open questions. We're using open questions about what they're allergic to, and that in making sure that they understand what their medicines are. So they're really important steps. So what we're looking to do is give nurses the opportunity at least once a year to reflect on what are best practice, be observed administering medications to the patient that they're looking after for that day, and then have a discussion and feedback about what they're doing well, but where are any potential opportunities that it may not be as safe as what it could be, and that these are the things that they can do going forward to prevent an opportunity for error. Pharmacists do this already, do this assessment on an annual basis, and prescribers are looking to do the same. This is where my PhD is, and my postdoctoral research is in implementing this across the whole of Metro North and statewide and nationally as well.
So essentially what you're saying is that all of us need to practice to keep perfect. And I guess it's because we can create habits or shortcuts that we're not even aware of that may increase the potential for error. So what you're suggesting is, create a reflective space every year where someone's observing your medication practice so that we can understand what we're doing well and then understand where there are any potential risks and then perfect that practice.
Absolutely, because sometimes we don't know what we don't know.
Yeah.
And it's an opportunity to identify that. There may be procedures that have come out when we've been on leave and we come back and we've missed those and we don't know that something's changed or that opportunity. And unfortunately, we do this sort of thing with new starters into the organisation and students, but someone that's been here for 20 years may never get told what they're doing well and where there's opportunities for improvement. And it's those staff as well that are teaching and role modelling for the new starters and the students. And if we're teaching them the wrong thing, then we're perpetuating the problem ongoing.
Okay, perfect. So now I have the very arduous task of trying to summarise all this fantastic information around medication safety. So your number 1 was the importance on communicating about medication both verbally and written. And a big part of this is that you were saying it's not enough to give a verbal order. It's really important that medications are documented with clarity, that they're documented correctly and concisely, and it has to be legible. And this has to happen even when there's a medical emergency. And you talked about particularly being wary of using abbreviations in case we don't have a shared mental model of what that abbreviation means. You said that it's got to be a clear transaction, and that's not always just me saying something and someone hearing it, and it's the importance of getting 2 nurses to listen. And I think Jessie made the point about not cognitively priming your partner for what you're saying. So if you want them to check a medication, you don't say, here, can you check that I have 2 Panadol here? And then they glance something, you say, can you check my medications? And then they say to you, is this 2 Panadol? And you say yes. Is that correct?
That's correct.
And importantly, you were saying that 30% of all deaths from medication occur because the patient never received it, that something has fallen down in our system, so that we really need to be very mindful that we follow through with any prescribed orders, that we double check that things have been given, and that one of the other written risks is around computers, to always double check that you've actually got the right patient's page open before you prescribe anything. And that 65% of all patients don't have their identification checked properly. Your number 2 is the importance of involving the patient as a core member of the medication safety team. And this was all about patients really need to be empowered to have knowledge about their medications. We don't want them to be passive patients. We want them to be aware of what medications they're on, what for, what time of the day they have, and if there's any rules or orders about that. And we want them to be independent. You stated that patients over 65 years of age, 20 to 30% of this age group get readmitted because there's been issues with their medication, either not taking their meds or taking too much of something. We need to use open communication, where we're not just giving a yes-no response from our patients, but we're giving them the opportunity to respond in a way that we actually know that they've understood and agreeing with what we are doing. And we need to be aware that lots of patients, particularly over the age of 65, can have hearing issues. We've just done a podcast on hearing. And so we need to check that if they've got a hearing aid or device, so that it's in when we're speaking to them about medications, and how important it is to check each time around allergies and around using proper names, because patients, as anyone, can get very confused by the different brand names with medications. Your number 3 is the awareness of the risks and safety processes for medications. So let's start with risk. You spoke to us about how important it is for us to understand risks, and that includes near misses, and the importance of us reporting all incidents as a way to learn lessons and identify any trends in potential errors so that we can actually change systems and processes. You spoke about how important it is to standardise what we're doing as a way to minimise error, and that standardisation for prescribing and administrating medications is extremely important. That 3.5% of medical error results in severe harm for patients. So this is a very important area. You said keep things very simple and clear, and keep meds in their original packages so that we can check expiry dates and we can check information and facts about that. Jessie made the important point about not storing similar medications in the same place where error can really easily occur. And you said to make sure that we always use our IV safe software. Your number 4 was the role of the multidisciplinary team in medications. And we want to start, as we've previously said, with the patient and their family and carer as real core knowledge around medications. And then we move to our prescribers, our GPs, of course our nurses, and the pharmacists. Each one of these people has a really important role to play, and we need to understand what the patient understands about medication and the dispensing of it. The whole team has a responsibility to understand the complete history of the patient and their medication, what they should be taking and what they shouldn't be taking. And you spoke about, even from a week's admission, that medications can change, things can occur, and that we need to check. And I think you gave the stat that 20% of changes of medication that occur on ward rounds don't actually ever happen. And the importance that the nurse has of being involved in those ward rounds, being part of the documentation and the follow-up, and just even being able to talk to the whole multidisciplinary team about how the medications are working for the patient. And finally, you spoke to us about why medication is everyone's business and individual accountability. And you spoke to us about, some of your PhD findings. So first of all, we want to make sure that we've got competent clinicians who know what they're doing. And you said that competency is a really important part of giving medications, but it's quite hard for us to assess who is competent and who isn't. So we start with our 6 rights of medication, that it's the right patient, the right drug, the right dose, the right route, and the right time. And then we move to our procedural steps where we're administering properly, we're complying with our hand washings, that it's sterile, that we're documenting carefully, that we're signing the drug off, and that the patient actually receives it. And the importance of engaging that patient in all of those steps. And what we want to do is, I guess what your PhD finding was, it's really important, like the pharmacist, that every year the nurses have an opportunity to reflect or be observed in their practice to understand what they're doing exceptionally well and to build on that, and to notice if there are any challenges or changes that would help make medication safety be improved. How did I go?
That's great. Thank you, Liz.
That was a lot of pressure today.
Great summary.
Karen, thank you so very much for joining us today on 5 Things.
The Royal Brisbane and Women's Hospital 5 Things Nursing podcast acknowledges the Turrbal and Yagara as the First Nations owners of the lands we now tread. We pay respect to their elders, laws, customs and creation spirits. We recognise that these lands have always been places of healing, teaching and learning. We also wish to acknowledge the First Nations people of the lands of our global community and encourage our listeners to seek out, listen and learn from the knowledge held in your shared space. As well as all major podcast outlets, you can find us at 5thingsnursing.podbean.com. Please also subscribe and give us a rating on your listening platform of choice. This helps others find the podcast. And finally, if you'd like to connect with Liz or myself on Twitter, we can be found at LizCrow2, and for me, it's inject_orange. We would absolutely love to hear your thoughts, ideas, or feedback. Thanks for listening to 5 Things.